Hi, and welcome to another episode of Malachi's Message, Toxic Mold Sucks podcast. I'm Elizabeth Kripe, Executive Director and co-founder of Malachi's Message. Co-hosting today is Emily Rochelle. She is our board chair and co-founder of Malachi's Message. Today, we have the amazing privilege of an expert episode with Dr. Amy Offutt. Dr. Offutt is an extensively trained integrative medicine physician who treats patients with complex health issues using a wide array of individualized strategies for healing. She cherishes her relationships with her patients and approaches her care, viewing each patient as a whole person. Her goal is to partner with patients to empower them to regain vitality, strength, mental clarity, energy, purpose, and a desire to share their gifts with others. Dr. Offutt was recently appointed by Governor Greg Abbott to the Pediatric Acute-Onset Neuropsychiatric Syndrome Advisory Council, or PANS. In addition, she serves on the board for International Lyme and Associated Disease Society. Dr. Amy Offutt, thank you so much. We've been looking forward to this. We just appreciate you taking time out of your day to join us.
Thanks for having me.
Today's topic, for those of you joining us, is, sorry, I'm used to Emily jumping in there. You're going to have to edit that out. Today's topic is Lyme and mold. Lyme disease is oftentimes a disease that is misunderstood. So before we dive into where we see a connection, would you mind just explaining to people what Lyme disease is?
Sure. So in the conventional understanding of Lyme disease, it's a bacterial infection. The bacteria is carried by a certain type of tick that's part of the Ixodes tick family. Initially, this was discovered in the northeastern United States near Lyme, Connecticut, which is why the name is Lyme disease. And a lot of people, unfortunately, still hold on to the idea that it only exists in the northeastern United States. Unfortunately, with the migration of animals, birds carry ticks, a lot of forest animals carry ticks. Even people can carry Lyme. And I know you guys have interest in sort of congenital transmission and things like that. That's another way that, if someone travels to the Northeast, if there are more ticks there with this type of bacteria and someone gets infected and then they, come back home and later have a child, there's a possibility their child might even have the infection, despite the fact that the child wasn't directly bitten by the tick. And that's actually been well played out in the literature. So back to the definition, acute Lyme disease is a syndrome that in Texas, I believe people are bitten by ticks who do carry Lyme disease. And a lot of them, when I see them later, say that they have been diagnosed with the flu, even though their flu test isn't positive. It's usually in the summer months, which doesn't necessarily match up with typical flu season, although we see flu kind of year round these last several years, and it's kind of a strange thing. So it's almost like a flu-like illness when it's acute. Some people have very mild symptoms. Some people can have more severe symptoms. And that's when it's first introduced into the human host. Later, this is where it becomes controversial amongst physicians and researchers. Later, the spirochetes or bacteria that cause Lyme disease that have stayed dormant after the acute infection is resolved, those spirochetes can perpetuate an immune issue or some inflammatory issues in the human host that can result in a chronic state of inflammatory disease. And so the debate is amongst physicians, is that really what's happening? Is it a chronic persisting infection that triggers chronic inflammation? Or is it just the post-infectious sequelae or, condition that occurs in people who've been tick bitten? One thing everyone agrees on is it's best to treat acute Lyme to prevent any potential chronic symptoms. And so in ILADS, which I'm a part of, you mentioned earlier, a lot of our focus is on early treatment, adequate treatment. I mean, ILADS, we believe people should be treated for at least 3 weeks after a tick bite and up to 6 weeks or even longer, depending on their symptom presentation and resolution, with antibiotic coverage. And that's sort of also debated amongst medical societies and clinicians. But I don't see, honestly, a lot of acute Lyme here in Texas because it usually doesn't get diagnosed acutely. It usually gets diagnosed later as a chronic, persisting sort of mystery infection where the patient may have gone to multiple doctors looking for answers and some relief. And sometimes they get small bouts of relief from a short course of therapy, but a lot of times they have persisting, debilitating symptoms that get them categorized as, a patient with psychiatric illness, or they will get diagnosed with things like chronic fatigue syndrome or fibromyalgia, or sometimes non-specific autoimmune disease, multi-connective tissue disease. When our training, it's really part of the initial training. My initial training here in Texas in medical school and residency was that Lyme disease doesn't exist here, and that, if someone came back from a trip to New England and they had a bullseye rash, I should treat them with, a short course of doxycycline and that would cure them. And what I've learned with experience and observation in my own patients is that that's really not true. So that's
what are some of the other misconceptions that you see quite often when it comes to Lyme disease?
It's interesting you asked that, because I do think a lot of doctors and patients too. There are some websites where patients will go online and they'll enter all their symptoms and it'll pop up and say, you might have Lyme disease. So a patient will come in and they don't say, Dr. Offutt, I have joint pain and mystery rashes and I'm really tired and have headaches. They say, I have Lyme disease. And, it's that self-diagnosis. And maybe they do, but maybe it's something else. So remember, ILADS is International Lyme and Associated Diseases Society. And we actually focus a lot on the associated diseases part, because as much as Lyme disease does exist, the associated diseases are often what makes the patients poor responders to just treating Lyme alone. So a lot of patients will call it Lyme disease when it may not be Lyme disease. It may be another infection that's provoking the same sort of symptoms or close mimicking symptoms. But I don't try to correct patients who say that. I usually will say, maybe it is, let's take a little bit more of a deeper look and see if we can figure it out. And so that's really my mission in life, especially as I get older. It's like, what legacy would I like to leave someday? It would be to have created a larger network of clinical professionals in Texas who recognize and treat sooner rather than later, so that we have just better outcomes and less suffering and just better care for patients who have these diseases.
Do you find, because a lot of people in the mold Facebook groups and a lot of people that I've spoken with, and I know Elizabeth has spoken with, they seem to be diagnosed with Lyme disease and mold illness at the same time. Is there a connection there? Or, because you mentioned previous infections, does the mold lower the immune system, or does it activate maybe a dormant Lyme infection?
I think if you dive in and you look at some of the mold toxins, if you guys, I'm sure, have looked at several of the reports, like when someone gets a mycotoxin test, it'll mention that certain mold toxins have effects on T cells and B cells, which are really just immune cells. And if the immune system think about it like maybe it gets a little overwhelmed or a little out of balance. We know in medicine there's Th1 and Th2 immunity. Those are T helper cell types, and autoimmunity and also allergy. Those are usually conditions caused by an imbalance of the Th1, Th2 immune elements. And so when you have, it's not an immune suppression like chemotherapy or, something like AIDS would cause. It's more of an immune imbalance. So a lot of people, as you guys have seen, who have mold toxicity or mold exposure, and they have the certain predisposition to have a sensitivity or accumulation to it, they are hyper reactive with regard to their immune system. So they react to smells and chemicals and medications. Like they can't sometimes say they come in and they say, I have Lyme disease. They may even have testing already done somewhere else that shows that they have the markers indicating Lyme disease may be present. You give them a therapeutic for Lyme disease and they call back and say, I can't take it. It could be that that's just not the right selection for them, but it also could be that they have that hypersensitivity, kind of histamine imbalance, like intolerance. And so I try to hash that out the first visit. I personally am pretty sensitive to medications and even supplements, and definitely to chemicals and smells. So I understand it from a personal angle. So with those patients, especially, I try to do everything I can to stabilize and rebalance their immune system and their histamine before even approaching any type of antifungal, antimicrobial or other therapy. They do way better if we approach it that way than to just go straight to treatment. Sometimes they don't like it because they came with the anticipation that I'm going to put them on a Lyme treatment. And we do get to it, but if you start straight away with that and they're sensitive, a lot of times it's not going to last very long before they stop it. I hope that answered your question.
Yeah,
It did.
it did.
It did. It's overwhelming how many people are diagnosed with Lyme infection and mold at the same time. We have a very dear friend that suffers with both. And it's just very hard and challenging for her every single day because of all the symptoms and how she's impacted by smells and chemicals and other things.
Well, other infections can also cause that sort of histamine imbalance. Sometimes, a lot of my patients are coming now saying, I have mast cell activation. And that's a whole other conversation, but it can all be somewhat categorized. A lot of researchers and I would say pioneering doctors are trying to wrap it all into a single syndrome. And really it's so multifactorial. Is it chronic inflammatory response syndrome, CRS? Is it just a mold problem? Is it an autoimmune disease? Is it Lyme disease? Is it Bartonellosis? Is it babesiosis? Is it Epstein-Barr? Is it heavy metals? I mean, all of that sort of has to be sifted through a little at a time. And then once, we don't always necessarily figure out which one may be the main one, but we start somewhere and then follow. I tell patients it's going to be probably a couple years of working our way through a treatment algorithm until you really feel like you don't need more treatment. It doesn't mean they have to wait 2 years to feel better, but it takes time. Most people don't show up within a couple of weeks of getting sick, so it's easy to reverse it. It's been going on a while, and so it takes a while for it to also get completely better. But it is controversial. And when patients come in and say they have Lyme disease, they may have Lyme disease, but a lot of them don't. A lot of them have Bartonella, or they have mold illness, or they have, or maybe they had a tick bite and they got multiple infections at the same time. And it looks like Lyme disease, but it may be really Lyme disease plus, that term has been used out there as well by some of the pioneering doctors, and ILADS is Lyme plus, which basically means there may be a spirochetal infection, but this is more than that, which means you have to treat with extra other therapeutics.
What are some of the symptoms? I know recently my daughter was bit by a tick and we just moved back to Texas, and I frantically started doing what I should not have done and just started Google searching whatever I could on what to be looking for symptoms after to make sure she was okay. But you are the expert, thankfully, and you are not just a Google search. What would you tell people to be looking for if somebody was bitten by a tick and they started to see various symptoms? What should they be looking out for?
So first of all, just having a high suspicion that it's a possibility so that you would think of it, because a lot of kids get a fevering illness and a sore throat or itchy rashes. Acute Lyme disease can have a lot of vague, nonspecific symptoms like fever, chills, exhaustion, sometimes a sore throat. That's not necessarily a hallmark feature. So most kids with a really sore throat and that's it, with high fever, it's not going to be Lyme disease. Joint pain, kind of almost confusion. The rash, the erythema migrans rash that is traditionally thought of as a bullseye rash, it's actually overemphasized as a clinical finding upon acute presentation. So a lot of patients don't get the bullseye rash. Some people get multiple bullseye rashes, and some people get atypical skin manifestations. There are some doctors out there that catalog these unusual skin lesions that are not the typical traditional bullseye, but are sort of a unusual looking skin rash. But people with acute Lyme don't have to have any rashes at all. And so if you have a high clinical suspicion as a doctor, like if I have a high clinical suspicion and I could treat a patient in that circumstance, I would start them on doxycycline and treat them for a minimum of 3 weeks. And if they're very sick, probably longer. One of the tenets of treatment is to treat until resolution. And the earlier, the shorter that time frame usually is, at least in my patients. So I would watch for a flu-like illness in the summer and then be thinking logically, like, was this child on a hike or did they go camping in the woods? Have they been, playing in the tall grass close to a forest area? Because if they haven't, it's probably more likely to be a viral illness they got from another child. It can look so nonspecific. I think that's why it goes undiagnosed acutely, especially here where we don't think of it at the top of our list of possibilities most of the time as a doctor, even in acute care, urgent care. Whereas say if you live in Connecticut or Pennsylvania or Virginia, a child comes in, they have a high fever, they look sick. I'm pretty sure the doctors there go, did you go camping or hiking, or have you played in the tall grass? Have you checked for ticks? And I think the nurses probably even check them for ticks. I don't know that to be true. That's my made up kind of thought of what it might be like to live there. But here we just don't think that way. Here we think more summer flu or flu, even if flu's swabs are negative, or strep. And the bullseye rash often will get misdiagnosed as a fungal, like a ringworm, when it really isn't even all that typical, but it's round, it's red at a quick glance. I've had that where patients say, oh yeah, I was at camp, I came home, I had high fever, I had a ringworm, and it probably really was neither one of those. So.
That's interesting. You're making me think of whenever I grew up and we were little and going through elementary school, because my mom lives on acreage in Sour Lake. It's a small town in East Texas. There's a lot of ticks. We had horses and cows and we had children and we thought it was a ringworm. They would show it to us, at school. Now I'm thinking they probably had Lyme.
Well, and they could have. I do tell people the other thing to keep in mind is, and I didn't make up these terms, but the terrain or the health of the person who is tick bitten very much influences what happens to that person. Back to the mold, if someone's already kind of chronically unwell and they get tick bitten, they're much more likely to have a much more severe case and long case of sickness compared to a very healthy person. I have patients and parents sometimes that come and say, how are we going to make sure he never gets exposed again? And we're just not. I mean, there's some guidance out there for different ways to be preventative and proactive with certain kinds of repellents and clothing, and the way that even things like Dr. Alexis Chesney was on the ILADS board with me before, and she wrote a book about preventing Lyme disease. And just putting your birdhouse at the corner of your yard, because birds, if a tick drops off of a bird in the center of your yard, your children playing in the grass might get tick bitten. And not to make people afraid, but it's part of life. If we get out in nature to be potentially tick bitten, flea bitten, mosquito bitten, spider bitten, And so not to take that lightly, but also not to stay indoors 100% of the time, thinking that's the best approach. I always give the example, if someone is a hiking guide in a national park that's in the northeastern United States, they just check themselves every day after their hikes are over. And if they find a tick, they pull it off. And they probably do take those extra precautionary steps to prevent tick bites. And some of them will get acutely ill after a tick bite, but most of them recover and they do fine because they're healthy. They hike every day, they get fresh air, they get sunshine, they eat a healthy diet, they sleep enough. You know, most of my sick patients, they were not living the healthiest life before they got sick. And whether it's, say, take an adult who's just working extra hours, not sleeping enough, feeling overwhelmed and overstressed, not eating properly, that person is so much more likely to not be able to handle an acute tick bite and the infection that follows than someone who is healthier. And we forget that. I think we kind of forgot that during this last couple of years too. If we could have used this time of COVID to emphasize some healthy lifestyle changes, and that would have been a good motivation, you know, like, let's get healthier. So if you do get sick, you can recover more quickly. And I think the people who kind of know it may have used it in that way, but there could have been a really nice big campaign for like, let's get healthier so we're stronger. And that would have helped even with other kinds of opportunistic infections. So considering the terrain of the patient who's sick is important too in evaluating what may happen to them if they get tick bitten.
I have a question. It's kind of on topic, but off topic, because during COVID, you know, the school started to implement a lot more chemicals as, you know, cleaning methods and stuff. Did that have an effect on your patients?
I've been asked that a lot. I'm actually a soap and water person. I've never even, this is personal, but way back when I used to work in the hospital for about 7 years, during that time, they implemented the little foam hand sanitizer stations right outside of each patient's room. And we were told, before you go in each patient's room, pump, you know, a couple of pumps of the foam, put it on your hands. I got the worst dermatitis, like extremely dry, red, itching, peeling. I had to quit wearing my wedding ring because underneath my wedding ring was just extremely peely, irritated, and itchy. And finally, I figured out it was when I started using that particular product. And I mentioned to you guys before, like, I'm personally somewhat sensitive to chemicals and things like that. I didn't use any hand sanitizer during COVID. I used soap and water. I wore gloves if I needed to. Like, I just, I do agree with you that like the chemicals can be really harsh. And I especially would cringe when I would see kids bring it in with their lunchbox. I saw some kids who had on their lunchbox I saw at my child's school, some hand sanitizer, and they would put their hand sanitizer on and then eat a sandwich. And I just thought, let's just go to the bathroom and use some soap and water and wash your hands. So I'm all for hand washing, but I do think there was probably more of an issue with that than people really realized. I don't think it was necessarily a focal point, but you know, did you guys notice that if you went somewhere traveling, like a lot of places, we went to Mexico summer or spring break 2021 at the resort where we stayed, everywhere we went, someone had hand sanitizer walking in a room, out of a room, into a restaurant, out of a restaurant. They were trying to make us do it. And they thought we were so strange because we're like, no, thank you.
Yes.
We literally would go wash our hands. So
yes. I'm like you. I don't use any of that because I'm now chemically sensitive, but so is my son. So whenever I heard they were implementing more chemicals in the school for, you know, preventative measures, I withdrew him from school because I can't have him in that environment. He'll flare.
Well, I was just telling a patient yesterday, I grew up in the country in Northeast Texas, and I was kind of taught as a child not to be picky, not to, do what you're told. Don't speak up. If you don't like something, just suck it up and go with it. So I always was a little bit, being honest, annoyed by people who would say I was with them at lunch and they would order their food and say, leave this off, put that on the side, and sometimes say I'm allergic to 5 different foods. Don't put that in my food. I would think, are you really? And then fast forward in life, and I personally started having some sensitivity, especially to fragrances. Like if I would buy a candle, or someone would give me a candle that was just a regular chemical candle, I couldn't burn it without feeling a little bit of a headache or like airway irritation. And I just thought, what is that? And then the same thing, like with the hand sanitizer. And I've had nurses that use Lysol. We haven't no Lysol in our clinic. We use a more natural, basically cleaner. And I love ozone because it's so well tolerated. But I just have my own self become pretty sensitive to even cosmetics and things like that. So I understand it when my patients tell me those things. And now I feel bad that I ever thought anything but nice things for anyone that was being selective about their food or their napkin, or I just didn't know. I think a lot of people just don't know. I did go do a training once years ago in Seattle. I was doing some IV nutrition training there, and I walked in and I had used like some hairspray or hair product, and it had a fragrance. And the lady at the desk said, I can smell something that's chemical. You have to go home and come back later when you get rid of it. So I went back to my hotel and washed my hair. And she said that's just their clientele at that clinic. And if you weren't sensitive or you don't have a sensitive family member, I don't think you would understand the degree of sensitivity that some people experience. A lot of them don't go out in public very much, so people don't understand what they go through. But I see some of those patients, and I definitely, every time we get new staff, they want to put a Scentsy in the wall, or they want to, bring the Lysol again. We have to start over and say no. And a lot of people just don't know. Like they don't have any idea that there's any issue with that sort of a exposure.
We actually went to a church once, my husband and I, he travels for work, and one of the churches we visited actually had a section away from everybody else that was for chemically sensitive people. And there were no perfumes, no lotions, nothing was allowed there. We've only seen it in one place, but we were amazed. We're like, somebody on the staff must be chemically sensitive, because there was no other way why an organization would have an entire section in a public place separated from everybody else. So it did feel separated, but it was really nice. You could actually go and sit down and not have to worry about, everybody trying to look nice. And it was in Texas, so everybody's trying to look nice and smell nice. And it's rare, like you said, unless you've been through it, you just don't know.
Mm-hmm.
Yeah.
I have a question, Dr. Offutt. You mentioned earlier in the beginning that a mother who is pregnant, that if she is positive for Lyme, that can actually transfer to the baby potentially. I feel that today it's almost like autoimmune diseases are so prevalent now amongst people and children. Do you think that kids are being born sicker today, or what's going on?
Well, there are a lot of different factors that probably contribute to the increase in chronic disease diagnoses in children. Kids definitely have a lot more chronic disease states now than I think. Some of the graphs I've seen, it started in the early 90s, and there are people out there that have hypothesized that it has something to do with the food supply or the increase in chemicals or plastics, or some people relate it to vaccinations, which that's a whole controversial topic too. I try to listen to every family story, because I believe parents. If a parent tells me that something happened to their child and they relate it back to a sequence of events that make it make sense, I believe what they say. So I think sometimes that is missing. I don't think it's one factor. And I think that's why it's so hard to figure out. Of course, if you say it has to do with the spraying of crops, you're going to get the food lobby upset. And, it does cost people money to change what they do. I do feel like, and I say this to patients all the time, we can't rely on the government to change it. We can't rely on the medical establishment to change it. Who changes it are really the patients and their families. So if the patients and their families as consumers want a different kind of food supply, and that's what they start asking for and paying for, the food industry will move that way. I do get frustrated because, for instance, like corn syrup was in everything for a long time and no one really knew. And then some of the labeling on, for instance, cereal boxes would say no high fructose corn syrup. But then you really turn it over and look at the ingredients and it has corn syrup solids in it. So yeah, it has no high fructose corn syrup, but it still has corn. So like people have to really, I feel sorry for kids these days. When I was a kid, we ate whatever we wanted. We didn't read labels. We didn't know. So we literally just, eating was just a part of our day. It wasn't like we had to ask for, a certain kind of food. I mean, I have 7-year-olds that come in my clinic that they'll say, Mom, I'm starving, I'm hungry. And I'll say, well, I have some snacks. Can I get you a snack? And they'll say, well, is it gluten-free and nut-free? Is there any soy in that? And they're 7, I just feel for them because they're already sort of overwhelmed by toxicity and restrictions. And like, what is that? We should be all collectively studying the root causes of that and then find the workarounds. So there's less suffering. There's so many more allergies now than there ever were. There's so much more autoimmunity than there ever was. It's just, there's got to be more study. I think most of it ties back to effects on the immune system, which is largely in the digestive tract that, as you guys know, there's a lot of tolerable levels of mold in things like cereal. All these snacks that kids eat, like I've never actually tested a box of Goldfish or Cheez-Its or any of those things, but I gave those things to my kids when they were small because that's what I saw other parents doing and I just didn't know better. And then as time went on and I really started learning more about food and what's in food and what food does to the immune system and to just general health, we started working in our household to eliminate a lot of those poor quality foods, nutritionally lacking and lots of just empty carbohydrate calories with food dyes and additives and chemicals. And I could see a huge difference even in my own kids' health and my own health. I felt better when I stopped eating that way and started eating more really logically, like what we put in is going to show up in our health. So like the blueberry farm we were talking about earlier, like things like having that close by is we have a strawberry patch here. I think a lot more people are gardening, a lot more people are going to farmers markets and just starting to really try to source their food from better quality sources. And I do see it make a difference. I have some kids that say they have mild PANS and they change their diet and they get better. Like they don't necessarily have to go all the trouble of IVIG and a bunch of antibiotics and immunomodulatory drugs. They just needed to stop provoking some of the immune inflammation from their diets. So that's always a really important foundational thing is diet. So.
You brought up a good point about the labels. I was listening to a podcast a few weeks ago, and it was about CBD. And they were talking about how they test their CBD for mold, but then come to find out they only test to see if it's positive for Aspergillus, but none of the other molds. But they were labeling it as, no, we tested it, it's negative, but come to find out it's negative for one mold. There's tons of more.
Well, that's like with Lyme disease testing. A lot of the regular testing it's very narrow. It's not fully comprehensive, which is why you're going to get a lot of false negatives if you use sort of the standard testing. So when we test, we usually use the specialty labs that do a more thorough checking, more antigens, more antibodies. So you're just much more likely to get a true reading. And of course, none of the testing is perfect. All tests have a certain level of validity that whoever's using the test should know. And I think what we're taught in medical school, if Lyme disease doesn't exist here, we don't need to know a lot about it. So then when we do have it, or we think we have it, we test with the typical test, which is really a more directed toward surveillance. And if we test with that test and it's negative, we tell patients, oh, you're negative, but we don't tell them what to do to get well or to feel better or what it is. We just tell them that's not it. And I think that's really kind of sad for the patients. That's when they start feeling unheard and a little bit lost, is when, and some doctors won't even run the test, even the basic test, because they say we don't have it, so that's not it. It's kind of a sad situation. So that's why I really am focused on volunteering in an organization that helps educate more providers. Usually the people that are drawn to ILADS are the ones that see that their patients aren't getting well and they want to figure out what else they can do for those patients. So, and those are my favorite doctors. So I'm sorry if there's background noise. They're actually building a pool at the house next door to my house. And can you guys hear that? There's a little, I don't know what they're doing, but it's kind of loud.
For the summer, at least they're getting it in now. It's off season.
Yeah.
What would you recommend? So if somebody thinks, hey, either myself or my kid, I think we might have Lyme disease, what would be the first steps that you would tell them to take?
Probably honestly ask themselves those questions we talked about earlier. Does it make sense? Where were they? I mean, there are a lot of resources. Like there are a lot of Lyme disease organizations that are patient advocacy organizations. ILADS is very directed toward educating medical professionals. I love helping patients too, but if we're working on educating, like it sort of helps, I think, if an organization is patient oriented. Those patient oriented organizations are a good resource for like maybe finding a doctor close by that can do some testing. Because, you guys know, like even like with the mold, the same thing happens. Like a lot of doctors don't think mold causes health issues. And so you wouldn't want to go to just any doctor. You'd want to try to find one who actually understands the approach and understands how to evaluate the patient. But I think if someone really thinks they have Lyme disease, they need a doctor that understands it too. And to get that doctor to work with them to get them on the right treatment path.
We want to, before we kind of jump off here in a minute, we want to make sure we highlight too the fact we talked earlier that you work with a PANS advisory council.
Mm-hmm.
And that's incredible. And I remember actually our friend who we were talking about earlier that has Lyme disease and mast cell, her daughter has PANS. And I remember years ago her starting to get really excited and saying, I think they're creating this advisory council. I've been hearing rumors of it. And it's incredible that that's actually happening. Would you mind briefly just kind of sharing what that advisory council is doing and where people can get some of the resources that y'all have created?
Sure. So the way the council was formed was a mom here locally. Her son had PANS and they just couldn't find a doctor to approach it in a way where he could get treated with the right treatment. And she had someone actually call Child Protective Services on her because she didn't want to put him in the psych hospital. And I tell her all the time when I see her, that was such a good thing because it poked her in the soft spot that made her want to actually take some action to do something about this. And so she was the one, it's Cara Chastain in Burnett, and she is the one that went to the local legislators. She went to Terry Wilson, who's our local state representative, and he and his team drafted a bill to basically develop the council. And it passed the first time. So we have like 14 spots on the council. It's a mixture of different professionals that have different inputs as far as PANDAS goes. And we worked really hard the first year to just draft a full report that we could give to the legislature that describes the statistics, the disease, how it's diagnosed, how it's treated. We have 3 subcommittees that, each committee is working on things like awareness, how to get the school systems to recognize it. A lot of school nurses are a good resource, school counselors, school administrators. The more people that understand what it is and can watch for it, the quicker a child gets treated, the better that they do. It can be very mild, or it can be severe. It's basically where a child develops acute onset obsessions and compulsions that are disorderly, as well as sometimes a severe aversions to food. So some children just won't eat for days, or they won't. I had one child that would not swallow her own saliva. I look at those as almost a different way of having an obsession or compulsion, like an obsession not to eat, or a compulsion even not to eat a certain type of food or a certain texture, or like a food group. Those are the 2 major criteria, and this is a clinical diagnosis. So one of those 2 would need to be met to be able to be diagnosed. And then 2 of the 7 minor criteria, which are things like anxiety and insomnia and bedwetting and ADHD, learning issues, separation anxiety is really common in little kids. They don't want to be away from their mom or their dad. Anyway, so the whole council was formed to improve awareness, to push for more research, to push for more resources to help families get treated. It's very similar as mold illness and tick-borne or flea-borne illness, because we need more awareness. We need more research. We need more caregivers and clinicians who understand these things that can treat these families and these patients. And so with the PANSAC, you asked about resources. We do have a website. If you typed in Texas, I think Texas PANSAC, Pediatric Acute-Onset Neuropsychiatric Syndrome Advisory Council, our website would pop up. It's part of the HHSC. And on the website, you can access the report that we wrote. And in that report are the steps to follow, even if, say, a doctor, someone's pediatrician wants to learn more about this disease, they could pull our report up and read in the report itself. How's it diagnosed? How do you work it up? What labs do you get? What makes you clinically suspicious that this is what's going on with a certain patient? And then even how to start the treatment. So even treatment is discussed in our report. And each year we're, updating the report to look for whatever's new out there in the world of research with regard to PANS and PANDAS. Some people also don't think it exists, kind of like the Lyme disease. And I'll tell them, go to the Stanford University website that describes PANS in depth. You can link from their website, you can link to even the NIH or NIMH, National Institutes for Mental Health, working group reports that describe what it is, how it's diagnosed, how it's treated, how you do a lab evaluation. So there's resources for doctors out there who, when we become doctors, our role is to care for our patients. So if a doctor were to have a patient presenting in their clinic who had acute onset obsessions and compulsions, or wasn't eating and had some anxiety and maybe some trouble in school, which how often do you guys see that combination these days? I feel like a lot of kids have some variations of that constellation of symptoms. Those kids at least deserve the workup. They may not actually have a root trigger that's easy to find, but if you treat those kids for their neuropsychiatric disease with the root cause approach in mind, they get well, and then they don't end up spending the rest of their life on psychiatric medications or in and out of psych hospitals or in jail or in trouble or struggling. So it's a huge huge step in the right direction just to recognize and look for it and start to treat some patients. And so I hope the PANSAC, that's really the PANSAC goal, is to create more awareness and more resources for families. And it's pretty easy to find on the internet. So
We'll make sure we include that link too. We had said that earlier. We'll include that link with this interview.
okay, thank you.
People can find it. Yeah. Thank you. This was so insightful. Thank you so much.
Thank you.
Emily, do you have any other questions you'd like to ask
I have like 100 more.
for this interview specifically? For the
No,
okay.
thank you, Dr. Offutt.
Thanks for what you guys do too.
Yeah, it's our pleasure. It's kind of our piece in this. So we feel honored that we get to help people.
All right, well, have a great